is the future of treating stiffness? I think we're on the exciting frontier of lots of possibilities, and I'll just give you a few examples I've been able to find. I think you and I will definitely incorporate cortical repatterning as a core part of our rehabilitation of stiff joints. I think it will become a larger and larger part of our understanding of how to affect change in a joint that's really stiff. North Carolina State University, where I live, has developed silver nanowires. These are small sensors that are wearable, stretchable, and they can monitor the motion in any joint at any time to give the patient or the therapist feedback of the pattern of motion. Perhaps there would be a way to retrain motion with an approach that's less cumbersome than the active redirection orthoses we've shown. Mirror visual feedback has, since 1966, become an increasingly large part of rehabilitation of multiple problems in the upper and lower extremities. This is retraining of the brain, and perhaps we will find a valid use for this earlier in our treatment of the patient who has a stiff hand. A more recent study looked at immobilization and what could be done to alleviate the effects of immobilization. There was one subject with an arm immobilized who looked at a nature documentary. This subject observed a hand doing something, and this subject imagined their hand doing the same task. I personally was surprised by the results of the study. Before they looked at the TV screens, the brain activity was similar in all subjects. But afterwards, it's really obvious that observing action created more intense brain activity in the motor areas that are needed to accomplish motion. A surprising finding, but perhaps here is a key to the future of how we can keep the cortical representation alive. A 2012 study looked at preventing this cortical disruption when someone's immobilized. They immobilized 8 subjects, all the fingers, the thumb, and the wrist, and they applied vibration to the points highlighted here in different colors. There was a group of controls that received no stimulation. After 5 days, the immobilized group with stimulation had preserved the sensory motor networks, but those who were controls and had not received stimulation had significantly altered representation as a result from the immobilization. So perhaps there will be other avenues for input that will prevent this cortical reorganization. After all this discussion, what are the conclusions? My conclusion is that the question, I believe, is no longer about passive dosage. I think active redirected motion is the future. It provides the ideal dosage, and most importantly, it provides it on a level of both mechanical and cortical stress that is needed to regain range of motion and reintegrate the motion into the normal pattern. We need to actively change the mechanics in order to change the motor cortex. These two can no longer be separated. There is additional information on our website available to you. The references above are available in PDF format for download, and there are clinical pearls that specifically explain in detail the interosseous and lumbrical muscle tightness testing. Many participants have said that succinct conclusions are helpful to them. Therefore, I offer these comments. Stiffness is a fixation of tissue layers, and it is due to basic changes in collagen, which result in abnormal cross-linking. Early motion prevents these changes and usually recreates normal motion. A stiff hand will demonstrate a maladapted pattern of motion, and therefore active range of motion is unproductive without blocking, and passive range of motion in a stiff hand has only a temporary response versus long-term change. There is modern evidence that we may use splints or casts to increase range of motions effectively, and that passive range of motion can increase range of motion, but usually that is passive range of motion. We do not know that it's active. I would offer that we need to be asking what is the problem specifically and what is the best solution, instead of what is the best orthosis. Collagen is a unique combination of flexibility and strength, and when there is joint stiffness, it is due to cross-linked collagen due to immobility and or new disorganized collagen that does not allow motion without increased resistance. If we immobilize joints and we remove the stress to tissue, this begins basic changes in the physical properties of collagen and results in joint stiffness. There's an increase of cross-linking, there is a decrease of the lubricants, and there is a increased collagen turnover. Immobilization alone can create stiffness. With immobilization or stress deprivation, there is a marked cortical response where the motor cortex representation diminishes, and the longer immobilization or limited motion is present, the greater the decrease in motor cortex representation. Edema does not cause stiffness, but it does cause stress deprivation because it prevents motion. Early on, it is a major cause of stiffness, and as the hand becomes more chronically stiff, the inflammation as a result of chronic edema tends to prolong the vicious cycle. Interosseous muscle tightness is often the greatest contributor to prolonged joint stiffness of the fingers. It is poorly understood, underappreciated, and undertreated. Blocking the MP joint in extension allows both interosseous and lumbrical muscle elongation, and therefore is often an appropriate starting point in mobilizing the stiff hand. The tissue response to stress is positive in response to motion because it maintains lubrication, prevents abnormal cross-linking, and orients new collagen fibers. The human tissue is viscoelastic. Collagen stretched or passive range of motion returns to the original length and shape, and therefore our goal is a plastic response where we're able to change the collagen by the frequency and duration of the stress applied. Studies have shown a negative response to passive range of motion, but in my opinion, gentle, sustained passive range of motion is appropriate with early stiffness, but the stiffer the hand, the less effective it is because it's short-lived. What we need instead is a more prolonged, repeated stress to change both the tissue and the cortical representation, and most of all, to prevent a revisiting of a maladaptive pattern. We have a significant cortical response to movement. It is magnified when we use certain muscles. We have learned much from constraint-induced therapy, including the technique of shaping, which may help us with our chronically stiff hand patients because we can reactivate previous cortical mapping. Traditional treatment has been shown to be less effective in treating both the chronically stiff hand and the CVA patient. Treatment of the stiff hand consists of passive force, immobilization, and constriction because often it is based on an unproven assumption that passive range of motion is necessary prior to gaining active range of motion. Casting motion to mobilize stiffness, or SIMS, is a treatment approach that uses cyclical active motion within a cast to mobilize stiff joints while concurrently repatterning the motor cortex and pumping the stagnant lymphatic system. Active redirection is using the new belief that active motion can increase passive motion, and its advantages are differential glide in both directions, reduction of edema, and cortical remapping, all of which occur simultaneously. What is the future? Cortical repatterning as a core part of rehab of stiff joints, perhaps wearable sensors, greater use of motor visual feedback, perhaps cerebral preparation during immobilization, or illusionary movements by use of vibration.